got another special treat. I've been hearing a ton of great feedback on the keynote presentation this morning from Dr. Parinda Khatri. We really lucked out. We convened our agenda committee, and they said, you gotta get Parinda, and she was available, and here she is, and I look really smart, so works for me. So anyways, without further ado, we'll once again we'll have a skill session here with Dr. Parinda Khatri, who's the Director of Integrated Care at Cherokee Health Systems in Knoxville, Tennessee.
Thank you. So we have people kind of spread out, but I've been informed I'm too short to be at the podium. Apparently they only got my forehead this morning from the filming, so barring like stilettos, which I don't want to give on. I'm going to stand here and then I will try to balance because I know people got people spread out. So I'm going to talk today about just the clinical competencies involved in integration, and I think that this is kind of the next step. I'm going to assume that everybody was at the talk this morning and kind of knows about Cherokee and our general model. And so what I'm going to be doing is talking a little bit more specifically about the clinical skill sets, but also how we have applied them in different settings. So, as I noted earlier this morning, we have clinics, 57 clinics. We have school-based clinics. We've got clinics in urban areas, clinics in rural areas. We've integrated behavioral health. We put behavioral health in primary care. We put primary care in behavioral health. So I'm hoping to just cover that span. I know that I've had several questions from people about those different adaptations. I know just recently I missed the earlier talk that Brian and are you Brian?
He's next door.
He's next door. Okay, so what I'm hoping that you'll see is our focus is really going to be on competency rather than specific discipline. It's really going to be on function because it is really about kind of what you need to do to integrate and develop a kind of a high-functioning primary care behavioral health system. And right now, they're not like tons of programs putting people out like this. So you have to assume that what you really want is a baseline set of competencies. And to be honest, the most important thing from my perspective is personality. Like, we can teach competencies, but there's a certain personality that just fits into this model. And then some people just don't. We've already talked about that. In the breakouts, you shared some horror stories, some of us, right? Some of the higher stories. Okay. So what I'm going to start with is just talking about the foundational concepts of the next hour. What I'm going to cover, one is to understand primary care, and I think that is critical because for behaviorists, it's not something that comes intuitively based on our training. When I went through graduate school in the early 1990s, I almost was trying to think if I could talk to a primary care provider. It really wasn't part of my world. I got, I think, excellent training in behavioral health and absolutely no training in interdisciplinary practice. And I never understood, like, how do they have different people in different exam rooms? Like, how do they work that flow? 3 people in one appointment slot? 4 people in one appointment slot? So we're going to understand, we're going to focus on some of that piece of it, changing our frame of reference and orientation to BHC practice. So what I'm really trying to do is focus on these core foundational concepts because they're going to set the frame and the structure for the specific clinical competencies. So let's start with just general primary care. When you think about just care in general, I like to think about it as like a triangle, like a pyramid, right? So the first line trenches is primary care. Secondary care is like all the specialists. So specialty behavioral health, specialty therapy, psychiatry, endocrinology, you name it, those are the specialty service. The tertiary care is like hospital care, and then the quaternary care is actually highly specialized, super specialized clinical interventions and procedures that will happen only in a small subset of hospitals. So what basically we're talking about is different levels of care, but if you look at the population, so primary care is the population that is the is really, really the kind of forefront, in the trenches. Folks, this primary care is really serving the main population, and then fewer and fewer people are served as we go up. So our goal is to bring the secondary care, the specialty care to behavioral health, some of that expertise to primary care to serve that primary care function, because so many people are served by primary care, and that's where the need is. So I talked about this earlier this morning. Then we have to think about primary care as a function, not a discipline. Just let that settle in. Family practice, pediatrics, internal medicine, those are disciplines. Primary care is a function. Any one of us are clinicians, we can perform the functions of primary care. For so long it's been tied to discipline, and we have to think beyond that, okay? So what are the functions of primary care? First contact, comprehensive, coordinated, and continuous. I went over that this morning. And then I also alluded that, that everybody else started adding all these C's, which are all certainly appropriate, and I actually had to reduce the number and synthesize, but I added some. We also wanted to be cost-effective, culturally competent, community-based, competent, good collaboration. So all those things, but now we are setting the frame, okay? So this is very important, because several questions have come up here. So I'm assuming everybody here is a clinician? Okay. If you're not a clinician, you don't have to raise your hand. I don't want to point you out. But the example I'm going to give, clinicians are going to get. Okay. So when we think about our frame of reference, we all have a certain frame that kind of really guides what we do and guides what we how we approach our clinical practice. And so why do we do the things that we do? Why? Why do we do the things that we do? This is really a time to challenge that. Really challenge, because in behavioral health training, for the most part, we are trained that to do a competent clinical interview or an assessment, it takes how long? When my first supervisor trained me and said, you need to do a really good clinical interview and you need 3 hours. How many people remember that? Yes, thank you. 3 hours and multiple pages, right? Then you learn that to do, you need an hour and a half. We used to get an hour and a half for the family therapy sessions and an hour. Where did that come from? Does anybody know? I honestly, I don't know. It's everybody seemed to decide it was an hour for psychotherapy, maybe 90 minutes for intake. Then it became the 50-minute hour. Then it became the 45-minute hour. So now people are kind of set on 45 minutes, and I always find that intriguing, because they're like, how can you do this in less than 45 minutes? And you're doing it. And I just wonder, where did 45 minutes come? I remember when I was told I couldn't do a clinical interview in under 3 hours. So if you look to other fields, I'm going to let's sort of look back and say, why do human beings act this way? Why are certain decisions made? So I have 2 boys, and one thing about having them is I learned a lot about all modes of transportation. Trains, automobiles, etc., etc. Okay. So my son was really big into Thomas and trains, and so I learned all this stuff way more about trains than I ever thought I would in my life. But I learned that there is a set distance between the tracks on a railroad. Does anybody know what they are? Wherever you go in the United States, it's the same distance. 4 feet, 8.5 inches, just so you know. That's your physics for today. 4 feet, 8.5 inches. Why is it 4 feet, 8.5 inches? Why is it 4 feet, 8.5 inches? Okay, let's go a step back. Well, the people who came over to set the railroad tracks in the United States basically were brought back. They used the models that were used in the Victorian railroad lines in England, right? They said, well, this is what we do in Maryland, England, and these are the Victorian railroad lines. So they used that framework. But where did the Victorian railroad lines come from? Where did they come from? They actually used the measurement for the trams, those horse-driven trams, because the ruts were already there, right? So you already had grooves on the road, right? So they just 8.5 inches. So they did that. But where did they get that? Why are these trams that way? Well, if you go back to the Roman roads, when the Romans conquered, this whole European area, you can see those were the grooves made by the chariots, were 4 feet 8.5 inches. Why? Why was that 4 feet 8.5 inches? Because that is the width of the back of 2 horses, and that was the chariots. The chariots really guided the railroad tracks, and that's why now, hundreds of years later, we have this 4 foot, 8.5 inches separation. Now let's move forward. This is the space shuttle. This is, also you learn a lot about rocket ships and stuff when you learn about transportation when you're playing with your kiddos. And if you look at those thrusters on the side, those thrusters on the side are how wide? 8.5 inches. You know why? Because they were built in these factories in Utah, and they had to be shipped by trains to the Space Center. And the reason I give this example, I don't want to belabor it, is we just need to question the basic assumptions why we do the things that we do. Why do we do the things that we do in primary care and in behavioral health? So as I'm talking the rest of the session, I may say things that are like, well, we would never do that, and I wasn't trained that way. And before you just reject it outright, I'm just thinking, consider where that came from. Because sometimes the reasons that drove the initial plan and the initial decision may not be operating now. And now we are working in a very different, very dynamic, challenging healthcare environment, and maybe we need to rethink things. So I just want to set that frame differently for you. Okay, now that I've done that, now let's go back to why we're here, which is, what are the goals of integration? What are we really trying to accomplish? And so this is what should set your frame now. Not what we've learned, not because we were trained a certain way. Now we want to think, how are we going to meet these goals? These are the goals that we came up with for our organization. These may not be what you come up with, but I wanted to share it with you. And the reason I have these written out, and I give them to everybody, is that it is very easy when you implement an initiative to get lost in the details. And sometimes you can get so lost in the details that you forget the original goal. Have any of you you've ever been in a meeting where you're trying to plan out something, and then somebody says, man, we need to figure out a way to speed up the intake process. And then someone says, well, the reason it takes long, one of the reasons is about pen. The pens don't really work, we don't have enough pens. Well, why don't we have that? Well, maybe we should order different pens. Well, this has been the problem. Who does the ordering? That person left. Well, I don't know, our contract has been with Office Max, so why don't we do Staples? Have you ever been in a meeting like that? Where it gets so derailed and you're like, oh my God! So, I have been in meetings like that. So I want to always say, these are our goals, guys. If you veer off, don't get lost. It is too chaotic. There is too much. There are too many pulls. You need concepts to keep you grounded and focused. So whenever you feel like getting lost, you go back to your goals. Hey guys, what are our goals? What are we trying to accomplish? So for us, identification of behavioral health needs. We know the need is tremendous. Most people don't come and present themselves and say, I have severe clinical depression. I also use alcohol. I'm sure that it affects my glucose control. Can you really help me with that? It doesn't happen that way, right? So we have to build in training and screening to help improve this recognition of behavioral health needs. Improve communication and co-management. Increase the availability of behavioral health expertise. Meet patients where they show up. Meet them where they show up. And for us, it was primary care. It was primary care. And when they need it. When they need it. Okay? We had, a few weeks ago, we had one of our primary care patients who'd never seen behavioral health show up. And she was kind of like glazed. And she said, I need to see my doctor. And so our checkup person, who was very sharp, she said, are you okay? Is this a medical emergency? And she said, I don't know. My Her son died in a skateboarding accident. He wasn't wearing a helmet. He was in one of the local skateboarding parks, which actually now I think they're trying to name after him, but he died. And she was in shock, and she didn't know where to go. So she goes to her doctor, right? So she didn't need to see the medical provider. The front desk person came and called me and said, this person needs help. Now, can you imagine if we didn't have a person who hadn't kind of gone through what our goals are and said, I can schedule you for an intake? She didn't need that then. She needed it where she showed up. She needed it right then and there. So that's why it's very important. She got trained in this. We need to meet patients when they show up. And then the other piece of it is we would like to focus a lot on prevention and at-risk intervention. It really, this is my soapbox. I promise I won't go on so many, but we are a very pathology-driven healthcare system, right? You have to be really sick before you get access to healthcare. Well, that's just ridiculous. You know, we all could benefit from good coping skills, good self-management skills, good communication skills. We really need to be thinking about addressing these issues before problems develop. And my guess is it's going to save money in the long term, but ironically, we don't get paid for prevention, right? But we wanted it to be a priority, which is why we had our behavioral health folks in child checks and in our well women exams. Okay, but that's one of our goals. Doesn't have to be yours. I'm just saying write it down. And then triage and coordinate with specialty health. This was another biggie because we wanted to make sure just because someone felt like they were going to the specialty mental health sector that they were like lost to primary care. Okay? These are our goals. If you just a recommendation from me is if you're going to implement it, write down what you want the goals to be. Give them to everybody. Make sure everybody signs off on them. And then when you're in a meeting and someone is driving you crazy, and you can just say, stop. Is this really addressing the goal at hand? Okay. Yeah, no. Whenever I give that example, everyone's just like, yes. Okay. So clinical model, I've really gone over in more detail this morning, but basically we want to make behavioral health routine, and it's going to mean shifting the boundaries of care, and that's going to be not just proximity, where you are, which is absolutely critical, but it also is the kind of person you get to be a behavioral health provider. This is a very different world for behaviorists. The pace is different. It's a much faster pace, okay? And it's faster like in every way. So many years ago, we had an internship program and we had an intern, and he was a great clinician, but he came to me and he said, everybody walks so fast here. It's true. You know, they're like, everybody's like walking fast. So those kinds of things are important. The scheduling is different. Our scheduling mirrors that of a primary care provider. My clinical template, when I see patients, is similar to a primary care provider's clinical template. In fact, whenever there's a question about our behavioral health folks, people will say, how should I set up the schedule? Should they have access to this appointment software, to labs? Whatever the answer for primary care is, I'm like, what's the answer for the primary care provider? That's the answer for the behavioral health person in primary care, because they're all part of the primary care team. So that really, again, goes back to that foundational, that core concept that I talked about. The schedule is different. The intervention and the whole mode of operation is different. We are really that person's care team member for their life. It's not an episode of care. That's what I love about being in primary care. I have seen 3 generations. Because in primary care, one time, one of my first few years working in family practice, you know, in specialty mental health, you trained like, you know, dual roles, conflict of interest, you can't see different family members, and remember, that was ingrained in us. Everything has got to be very clear. And so then I had, in this rural family practice clinic, I saw the grandmother, I saw the granddaughter, and then the mom, who'd been in prison, was released from prison, came to primary care, the primary care provider got me to see her, and I said out loud, you know how sometimes you're like, why did I say it out loud? I was thinking it. I'm like, oh my goodness, I'm already seeing the grandmother and the granddaughter. But I should have just said, fine, and the medical director of that clinic said, Parinda, welcome to primary care. That's what a week, do you? You go when you need to go. Maybe you don't need to go for a year or two. Maybe you need to go regularly because you have a health condition for which you need to go regularly. And it's the same thing for behavioral health. So think of it that way. That really shifts the frame. Okay, the notion of confidentiality, really we have to look at it in a different way as behaviorists. Today, in today's world of HIPAA and all that, let's be honest. Our documentation is not our documentation, okay? That is a clinical record of the service provided that belongs to the patient. When I was training, remember we would do our progress psychotherapy notes, and then we would do process notes. We would keep 2 separate files. It was crazy, and even then, I mean, it was very long. And I tell people, I'm like, let me just tell you, they were beautifully written, okay? 6 pages of conceptualization and da-da-da-da. But nobody wants to read that. Basically, what we have to think about in our documentation and the sense of confidentiality is anything I write, I need to feel comfortable that 6 other people are going to read it. It just is the way it is. And honestly, if folks in the mental health world who operate in specialty mental health, I tell them that too. I tell our specialty mental health folks, just think, whenever people do records release or whatever, you don't know who's going to be seeing these notes, so just think before you write and have that kind of in your mind. In our system, people sign one informed consent. We explain our model of care. We just say, look, we're an integrated system. There are going to be different providers who provide care based on your needs. And we cover kind of our, we're a licensed community mental health center and a FQHC. So we actually cover all the informed consent components for mental health, which is typically much more restrictive, right? So we go over these are the times in which we would have to break confidentiality if you're at risk to harm yourself or others, if a child is at risk. So they get all that in the get-go, so we don't have kind of any confusion in the beginning. And then I will repeat it again. I believe in true informed consent. I'm a part of the primary care team. I'm trained as a psychologist. I'm acting as part of primary care. The things that we talk about are really part of your primary care service. And your primary care provider and I are going to be working with you and talking about how we can help you with your pain or smoking or your anxiety, whatever often the words that they use. Documentation I've talked about, but I think that's really critical. There have been, I think, a lot of misunderstandings about what HIPAA is and what you can document, what you can't. I am just saying, as a system that is integrated, I think it'd be very difficult for us to operate if we did not have shared documentation. Frankly, by the time I get into the room with the person, I have until 3:15. Yes?
Yep.
Okay. By the time I get into the room to the person, I already know a lot because I've read the medical chart. I've reviewed the last medical note, I've reviewed the labs, I've reviewed what meds they're on, and I've reviewed the problem list. I go in there armed with much more information than I would if I was in specialty mental health and I was going in cold, right? So when I document, it's with the understanding that I don't have to repeat all that stuff, all that social history, all that stuff. It's amazing what primary care providers know a lot about that. Okay? Some of our primary care providers, I tell them, I said, do you know you have an entire traditional intake in your note? You have so much information in your new patient note. And then this is a key thing, thinking about a population versus a case. This is not about your caseload. It is a population focus. And that is, I think, a big shift for primary care providers. So let's now move to the nitty-gritty details. What does this mean in reality? In reality, it means that the behavioral health provider has to have a schedule that mirrors the primary care provider's schedule. In our system, our primary care provider, if you look at their schedule, they have planned visits and same-day sick, right? The planned visits is where they have their planned follow-ups, right, for chronic disease management, follow-up for whatever condition. The same-day sick, acute care slots, what's that? That's for people who call in that morning, call in that day, and they're sick, right? When I call, if I'm sick or my kid is sick, they need to be seen that day. I can't wait 3 to 4 days, right? So we have same-day sick slots. to check out people at the clinic where I worked in. Tasha, I remember her name. She was putting in a new patient a warm handoff a consult for me, and she said, Dr. Khatri, you're like on demand, like that on demand cable movies. You know, like Comcast on demand, you get on demand. And I said, yeah, that's kind of like cable TV. So she started saying, she and I had this thing where like, I got it on demand, I got it on demand. And so then we just call them, and now to this day, we call them on-demand slots, which means those are the slots that we use to bring in for our new consults. We will individualize those demand slots based on the volume needed in primary care, which is different with every clinic. So for example, the clinic I work in, it's pretty steady throughout the day. So we will have a 10:30 to 11 block and then a 2:30 to 3 block. A couple of days a week, there are Tuesdays and Thursdays, I don't know why, we routinely get five consults at the same time between like 3 and 3:30, or sometimes 3 and 4. So there are typically 2 or 3 of us covering the clinic. We will always put additional blocks in at that time. Friday at 4:30, don't ask me why, but there is always the suicide, patient who is suicidal. It's like clockwork. And then, no one's allowed to talk about it because they'll say 4:55. They're like, we made it! And I say, no! And then someone will walk in, right? So that's our clinic. In our pediatric clinic, Tuesdays are the days where we have all of our pediatric providers. We have 4 providers there. And it's very, very high volume. And our pediatric BHC called me and she goes, I'm getting slammed. I have my follow-ups, and I'm getting like 12 consults before noon. And she's like, there's no way I can do it. So she was the first time ever, Tuesday for her is a blank slate. It was a blank slate. We've never done that before, but it's because the volume was so high. Then we actually turned that into our ADHD days. We had so many people come calling in. No, we had so many families calling in. So you know what happens around the first report card, September, you start getting all the phone calls. So then we made that our ADHD clinic day. So anybody who calls into the pediatric clinic, and anybody who says, I want my child may have ADHD, they need medicine, the school says they need Ritalin, yada, whatever, they get scheduled on a Tuesday, and they get block scheduled with both the behaviorist and our primary care provider. So then, and we have a protocol that we develop. In another one of our clinics, we have, in the morning from 8 to 12, 4 providers, and then 3 of those providers work part-time, so they're gone in the afternoon. So what we do is we have lots of on-demands in the morning and almost none in the afternoon because there's only 1 provider. So that's where all of the planned visits, follow-up visits are. So the schedule really needs to mirror. So pay attention to the volume and flow in primary care, and it will change. We will change this about once a year because the clinic changes. But that's how you need to structure your schedule. Do what you need to do to provide that point-of-care access for behavioral health. Okay, so thinking through then the kind of the scope of how we consider our panel. Our panel, the BHC panel, is the primary care panel. There's no such, that's not my patient. It is my patient. If it's a patient of primary care, it is my patient. And that also means that you don't see patients. If you're a behavioral health provider in the primary care clinic, I don't see patients who are not primary care patients. And that is a tough thing for us. But you cannot, it's very difficult to serve 2 masters. It really is. And so the demand in primary care is quite high, and we want to fulfill the function of primary care. So our behaviors in primary care are only for our primary care patients. Now, we have a specialty mental health continuum. We have specialty mental health providers, and they can see anybody in the community. But it will happen, like people will say, my neighbor wants to see you, or my so-and-so wants to see you. We can't do that. There's got to be a way of containing and focusing on what you're doing. So be very careful about, again, what your scope and what your role and what your panel size is. So then the impact is measured on health status and functioning for the entire panel. So we are a federally qualified health center. We have UDS that we have to report, and we have HEDIS measures. These are all quality measures, healthcare quality measures. And there are things like hemoglobin A1C, blood pressure, low birth weight. Let me tell you, those numbers are the responsibility of our behaviorists as well as our primary doing as well as we like for blood pressure. So our BHCs and our medical providers are working together to say, what are we going to do about that? Okay. Sorry. Population-based care. Okay. So that is critical. All right. Let your patients be your guides. This is really this is why we even got into integration, because our patients were our guides. They showed up at our doorstep, and they would come and they would talk about the trauma in their lives, or that they were drinking too much, or they were fighting all the time with their kid. What are they supposed to do? You can't just be like that, you know? And it's just really not part of what being a good community provider is. So they showed us the way, and they will tell us. So I think that it's the same in everything that we do. There have been some programs we've developed that have been beautiful programs, but they flop because it wasn't with the patients, it just didn't click. It just didn't click, and I don't know why. We have one clinic with we do group medical visits for diabetes, and it's been a hit for 8 years. The data are excellent. You look at kind of the control, the numbers we track it every quarter. The data are really good. So we said, let's try it in our other clinic that's in inner city. And we tried everything. We gave food. We did, we said, we'll give you breakfast, come in for fasting labs. Our medical provider called every person on the list. We had like 3 people show up. I don't know what didn't click. And we really tried to make it work. Then we said, well, let's do a weight management group. And we did a weight management group. And oh my gosh. Everyone we have a demand for that. We're doing a DDT group. We already have a waiting list for the DDT group. It's just, you can't predict it, and then if one thing does well in one area, and then so it's sort of like, ask your patients, what do you need? They will let you know. We all know they let you know. Okay. So, what do we do in primary care? This is very important. What are our scope of services? I'm not going to go through each one, but it just lets you know there's a lot that we do that really encompass primary care. What I will focus on is what we don't do. What we do not do is long-term psychotherapy, traditional psychotherapy, psychological testing, disability assessments. We found we had to decide where we were going to put our energy to have the maximum impact for our population. You may make different decisions, but what we realized, if we had our psychologists involved in doing 3-hour testing for one person, they couldn't be seeing patients. That's like 7-8 patients they could have seen. So we had to make those decisions. So decide what you are going to do, but more importantly, decide what you're not going to do. That's going to be very important to let everybody know that. Okay. So let's talk about the skills and specific practice competencies that are involved. We wanted to go back to the scope of service, and I went over this morning. Consultation on chronic health issues, lifestyle and behavioral health change, and then helping, of course, manage those traditional mental health, substance abuse issues. That's what we have to do. So if we have to do that, what do we have to know? And in fact, there's been some really good work that's come out recently in terms of competencies for primary care practice, APA, published competencies needed for primary care practice. There's some excellent articles across the board on that. But in general, what we're seeing is we really do need to have a solid base in health psychology, behavioral medicine, and if you don't have it, learn it. But you need to know that if you have a patient with colitis, the intervention, the behavioral health intervention for that is different than that for Crohn's disease. Okay? You need to know what is, what's a CBC? Why is it so important to monitor Coumadin? Why is this so important to look at this number versus this number? So in fact, for all of our BHCs in their training, they all have to go through primary care medicine training. And then they shadow their primary care providers. So they speak the language and they know that. So this is one of those things, if you didn't get it in school, fine. There's really, really good information out there on behavioral medicine and health psychology. A good health psychology text, basic behavioral medicine text, and then keeping up to date on kind of the most recent research in the areas realms, and that's actually now with the web so easy to do. You'll be amazed how much behavioral health stuff is out there. It's like 50% behavioral health. How do you manage diabetes? So much behavioral health. What do you do post-MI, after a heart attack? So much is behavioral health, right? So this is an example of this. So this is what happened. This is an example of one of my clinical day afternoons. Okay, and I do this because I want people to see the variety and the flow and the pace. This morning, I was doing a seminar, doing a morning seminar for our new interns on the model. And they said, this is really interesting, they said, but okay, this was the beginning of the year. Can you just, we just want examples. So I said, okay, so that afternoon I tracked my patients. And so what you can see is I put in what's the new and what's the follow-up, which is the plan. The very first patient I saw, this 12-year-old male, was a new consult from pediatrics. This kid had gone to the ER so many times for stomach ache. And stomach ache is one of the most common complaints in children. It's also one of the most difficult. It could mean nothing, it could mean everything. And so then they usually do this big workup, and nothing had followed up. Nothing had shown up. And so then they come back to primary care, because usually when you go to the ER, you need to do a follow-up. And the ER, Children's Hospital, said, you got to go to your primary care doctor because we keep doing these tests. So often what happens is when they don't know what's going on medically, they'll just say, well, maybe a BHC can figure it out. And so I saw him, and it was a very, very complex family situation. The parents were in the middle of a very acrimonious divorce. They were, this kid was in the middle. The only time that they were not fighting and screaming at each other is when he was in the ER sick. Do you think this kid was going to get better? It really was this kind of classic triangulation. And so really to intervene, we had to do two things. We had to work with the parents, but I also had to work with him in terms of relaxation, coping skills, and separating himself. He was basically absorbing all that conflict somatically. And it just took a handful of sessions. And I saw him recently, and he's like, when I saw him, he was this, and now he's looking down, Dr. Khatri. So, okay, 40-year-old male with chronic depression, diabetes, hypertension. He was a follow-up. He's a guy that he sees a medical provider every 3 months for the diabetes and hypertension, and I'm scheduled with him back-to-back. Whenever he sees a medical provider, he sees me. The 50-year-old female with fibromyalgia, insomnia. Okay, this is one of the ones that if you can help primary care providers with some of these autoimmune disorders, they'll give you cupcakes and chocolate chip cookies, and they never want you to leave, because for many of these syndromes, there's not a lot of objective data, and there isn't this perfect medicine, right? It's not like ear infection medication. So with this one person, she could not sleep, and here's what the bigger thing. The medical provider came to me and said, every time I see her on my schedule, I get stomach aches myself. And the nurse is like, oh my gosh, and already there is this tension, right? And we all know if you've worked with people, not everybody is the same. Some people are considered higher maintenance than others. And what was happening in that session, he said, I never ever, I can never please her, I can never make her happy. And then, so when I did the consult, what I realized is, here's a woman really looking for validation of her suffering. And all it is she is experiencing true suffering. Her distress is coming out and showing itself physically. And he would come back saying, isn't this great? This test is negative, this test is negative, this test is negative. And he's thinking that that's going to allay her and to calm her. And what does that do? What does she hear? You are not listening to me. So in her mind, she ups the ante. She's like, he probably doesn't get how bad I feel. So then she ups the ante. No, this really hurts. This really hurts. I have this pain here, and I can't do this. And so as he's trying to calm her, she gets what? She gets more and more and more, because he's thinking that he thinks he's treating her when he's really not addressing the issue. And so that's 45 minutes of this. Nobody leaves that visit feeling good. Nobody leaves that visit feeling good. And so it's always something else, a lot of phone calls, and she couldn't sleep. I can't sleep. And she really couldn't sleep. So when I got involved, sleep was the hook for her, right? For the longest time, we've been trying to get behavioral, and she goes, it's not in my head, it's not in my head. But the sleep issue, he could say, she can help you with sleep. So we focused primarily on sleep hygiene, but more than that, we focused on re-engineering the entire flow of the primary care service. Number one, she got regular appointments, because if you waited for her, she got so anxious when she didn't have that medical appointment, she would just start calling until finally the nurse would say, fine, come on in. So we said, this is a unique situation. We really don't do it for most people, and we don't. But she was seen regularly. The other thing is, I always saw her first. And that's where you need to get your front desk person, your check-in scheduler, to know it's critical, because my job was to multifold, support her, provide some validation, and focus on functioning. Not focus on getting her to say she didn't feel bad or she felt better. That's not going to happen. With these kind of autoimmune chronic pain issues, it's not about telling them that they don't have, telling you, oh, I don't have pain. It's more like, let's give you a quality of life. Let's improve your functioning, right? So we took her distress, the goal of reducing her distress, off the table, because we were just going to battle that way. It was, what were you involved in that you're not involved in now? What did you enjoy? Because it seems like you hurt when you sit, you hurt when you lay, you hurt when you stand. If it's going to hurt, let's see if we can get you back doing things you enjoy. And then it was also containment. What's the one thing you want to focus on with Dr. Focus today? And so then that visit could be a 15-minute visit with him. One time, oh my gosh, we had a new schedule person, they scheduled this patient after him. Oh my gosh, white coats flapping. Oh, this can't happen again. Now I'm an hour late. And it was just the way that was scheduled. He flipped out. He was like, we cannot have this happen again, Parinda. We have to see this person first. So this is what came out from her. The 44-year-old female chronic pain suicide attempt, that was really heartbreaking. She really is in excruciating pain. And so I just see her whenever she sees her medical provider. Most recently, she came in because she had tried to commit suicide. This guy, my 50-year-old male, posted mine, history of substance abuse, and the meth lab. This guy, he is a success story. I will tell you, I saw him because he had gone to the hospital because he had a meth lab, and meth lab blew up, and he was outside, and the meth lab blew up, and the police arrested him, and he had a heart attack while he watched. So he goes and has a heart attack. He's never had any mental health or substance abuse treatment. It's a long history of polysubstance abuse. He comes in to see in our urgent care clinic as a hospital follow-up. And then, so they're looking at it, and they're like, oh, so, tell me about yourself. What happened with your heart attack? Well, I had a heart attack when I watched my meth lab blow up. And I've been using meth and all these things. And so they went, okay, well, I'm going to go get our BHC. And that's how I got hooked in with him. And this guy, he did not. He got into a drug court program, so they said you can either go to jail or do drug court. He did not want to go to jail. So he did. He's done really well. I saw him, we worked on the substance abuse, depression issues, and then it really became about weight management. So once he was sober, he had gained so much weight off drugs. He gained so much weight that his knees were killing him. He couldn't walk, and so then we worked on that. That was like maybe a year and a half later. The medical provider came back and said, he's back again, but he has gained like 85 pounds, and we have to work on weight management for him. So it's an example of just, episodes of care. New consult I got. This is one of those women, hypertension, diabetes, cardiovascular disease, and depression. New consult, the obesity and panic. This guy, my 54-year-old, I don't know if this happens in Oregon. This guy was like 640 pounds. We couldn't weigh him in our clinic. He had to go to the freight scale over at the university, but he was having panic attacks. And this is one where we were like, he's like, nothing helps my panic attacks. I can't breathe. And then that's when I did a consult with our psychiatrist, and he said, Parinda, I wonder if you really can't breathe. I wonder if one of the triggers is that, the poor oxygenation. And so we really 46-year-old female with grief. That was that woman, remember I told you, whose son died. So I saw her, that was new. And then my 13-year-old male with obesity, weight management. Remember I talked about our Project Diabetes, our pediatric obesity, we called it Project Diabetes because our goal is to reduce the rates of diabetes. But this was our follow-up. This was a kid who was in our pediatric obesity kind of track because he had tracked over the 85th percentile. And he was so overweight. This is my kid. Oh yeah, after school every day, his mom would take him by McDonald's, and he'd get that really big, super-sized sweet tea and an entire, I don't know how much he ate. But this was hard for me because he was on the football team, and Tennessee football is, and his coach did not want him to lose weight. I'm about to wrap up in it. Didn't want him to lose weight. So it was very frustrating for me because, he had some real disincentives to weight loss. Anyway, these are some of the core clinical practice skills. Make sure that you have consistent, thorough role definition for the patient. They need to know that you're here focused and targeted. Don't let them think that we're here, I'm going to be your therapist. It is, this is my job. I'm going to help you with sleep. I work as part of your primary care team, and I know that you talk with your medical provider about the fact that you're having difficulty sleeping. I'm going to ask you some more questions about that, and we're all going to come up with a plan. Okay? So very focused assessment, very, very focused interventions. We try to be empirically based as much as possible. Very focused. If you look at our assessment and documentation, it is not going to be like that full-scale clinical interview. It's really going to be focused on the issue at hand. The other piece of it is knowing how to measure functional outcomes and emphasis of using the patient and that self-management. The patient is the most underutilized member of the healthcare team. They are the most underutilized member of the healthcare team. We need to be having patients be more engaged. This is their life. We see them for what? 20 minutes, 30 minutes? This is their life. So we need to let them know for so long patients have been passively accepting care. It cannot work that way. It cannot work that way. So how do we get them involved in that? And then the basic knowledge of psychotropic meds. It's going to come up. So we have our psychiatrists do trainings and with our PhDs, and then we call them all the time. For every patient, any patient where there needs to be a psychomed recommendation, we will call our psychiatrist. What I did once, I asked one of our PCPs to give tips for our new interns. So what would you want our new interns to know? And he came up with this: do communicate the diagnosis and plan. Do not tie up an exam room for 30 minutes. Let me know if there's drug abuse, access to, and limited mental ability or literacy issues. That was just a little bit of a surprise. And then we always had to add it to the chart. And he says, don't refer a patient to somewhere without letting me know. He said this. Some interns had done that, and that really bothered him. Be decisive. You're the expert. This is hard for some of us in behavioral health because we're used to saying, well, in general, there's trauma and all these psychic issues and da-da-da-da-da-da. But they just want to know the answer. Or they just want to know, look, I think these are the issues while she's having difficulty sleeping. She has very poor sleep hygiene, and we're going to be focusing on X, Y, and Z to help with that. We need you to please reinforce that. Okay. Think 15 minutes, not 50. Oh yeah, he said always ask, this is the thing I mentioned before, I always ask about the locate, where are you in the flow? Where are you in the flow? Can I use the exam room? Should I pull them? Always be familiar. So the first thing I would tell anyone if you want to work in primary care is shadow primary care. See how they work. See how they communicate. See kind of how they move from patient to patient, because you are going to have to fit in that flow. And if you slow it down, you are going to be basically not utilized. Okay? He doesn't want much processing, and this is another one. A lot of interns want to show how much they know and how smart they are. So they'll say, like, they had lost experiences from very early childhood. I actually overheard an intern say this, and the primary care provider's like, what? Are they depressed or not? What do I need to do differently, right? So he wants to know, he always says, what's your assessment, what's your diagnosis, what's your plan? And tell me when you're going to follow up. care into our mental health setting. Somebody had asked me about that, but I don't think he's in the room. These are the tips for that. This was really critical for us because we were changing the entire culture of that clinic that has crisis stabilization, day treatment, psychiatry, case management, all the trappings of community mental health. We had one where a BHC, he really said at this point he had to be much more of a liaison. Because so many of their patients already had established psychiatrists, therapists, case managers, so he saw his role really much more as a liaison. And he's like, we need to help primary care understand psychiatry and understand behavioral health world. Then we've done behavioral health into primary care. This is just an example of one of our Lenore City clinic. This was a private practice that came to us and said, the guy said, I am so sick of dealing with my practice. I want you to take it over. And by the way, I'll get a behaviorist, right? You said that. So we gave him one. And so this was some of the tips that our BHC there said, look, you need to know that there's a very high volume, quick patient flow. Just accept that it's going to be busy and a lot of multitasking. Do not expect like a calm day, okay? You go expecting a calm day, you will be so frustrated. Just embrace it. Embrace the chaos because that's the way it is. So expect it, be involved in it, be engaged in it, get excited by it, don't resist it. Less attention, that was one thing one of our BHCs in that clinic said, just don't pay attention to boundaries as much. You're going to be interrupted a lot, be very focused, and just being part of that team. This was some tips that they had about integrating behavioral health into the medical culture. This is important. I think I've already talked about this. Know what the common labs are. Know what the common psychotropic meds are. Be aware of some of the legal and ethical differences. So this is a big deal. This is a big deal. For behavioral providers, we really, really can't see people who are our colleagues, right? In primary care, it happens all the time. Nurses and nurses' families, they see the doc. The doctors will see each other for care. It's not a big deal. And this is one area we've had to draw the line. But I've had multiple times, and this happens in every one of our clinics, where a nurse, it's very much an honor, right? When someone says, I think you're good enough to see a family member. I had our head nurse put her daughter, multiple times a nurse put their children and family members in my schedule. And then you have to go and talk to them. And they'll say, but they see the pediatrician, why they can't see me? So this is where some education has to take place, because we really can't. That is a real dual role. So just be aware of those differences. These are just some, again, review of some of the things that I've talked about before. These are some parting thoughts I just want to leave you with. Please remember, population focus, be flexible, relish uncertainty. It's okay, it's not a perfect, clean world. So like I said, just bring it into your life, into your consciousness, and just enjoy it for what it is, which is a wonderful way of contributing to your community. And it won't be clean and neat, but it really, really will be, I think, one of those significant things you can do with your professional life. So I'm going to stop there and just a few minutes for questions.
Do you have a software list of functional questions for that assessment at targeted assessment?
Yes. So I would look at, there are a couple of books. One is Hunter and Goody. Christopher Hunter and Jeff Goody have a very good book on clinical competencies in integrated primary care. Chris Hunter is basically the department manager for integrated care for the Department of Defense. So he set up the program manual for the military. So if you actually want to Google the Air Force, the military is integrating at MBA at a very, very dramatic level. And so there's a manual you can download for free. If you do Air Force Integration Manual, you probably don't want to do it everything their way because they have to be, it's very military. But it may give you some really good ideas. But it's like the 5 A's, and so that's, I think, a really good. Hey.
Hi. Sometimes I worry a little bit. I think integrated behavioral health gets perceived as an intervention for low-functioning people.
Yeah.
And there was an example that really opened my eyes, which was I was touring some facilities in Portland where it was pretty well developed, and I was sitting in a room with the physical health providers who told the story about one day at the end of the day, they called in the behavioral health provider to coach them on why they procrastinate their charting.
Yeah.
And they went on and on about how helpful it was. They changed a behavior.
Yeah.
And this was a group of really high functioning people.
Yeah.
It made me realize the value of this for everyone.
Yes.
And I think that's really germane when we're focusing on the Medicaid population.
Yeah.
And just realizing that this could benefit all of us by
Yes.
making the value of primary care more applicable in our lives.
Yep. Once now we've started our providers ask our BHCs to do resiliency training for them and for the staff because it's hard work. Yeah. Everybody, I'm saying behavior change, we all need it. Yeah.
So when you were talking about the patients there, a caseload between 1 and 5 in the afternoon and 9 folks, would you typically, if you were doing a seminar, see that many folks in the morning? I mean, how many a day?
Our average is between 12 and 15 a day. Sometimes I'll see 17, 18, sometimes I'll see 10. That's our range. Our pediatric folks will see more. They'll easily see 20, 22 because they're doing raw child checks. Most of our BHCs also do clinical supervision and other demands. But on general, when we look at, quote, I hate the word productivity. I hate that word. But, but it's around 12 to 15 are the numbers that our target.
And how many physicians would you be working with and to have that amount of patients?
We typically go 1 to 3 or 1 to 4 is a ratio, 1 BHC to 3 physicians or 1 BHC to 4.
As a follow-up to that, those new folks on that afternoon schedule, were those form handoffs or were those scheduled?
No, form handoffs.
I thought, okay.
Yeah, yeah.
Thank you.
Okay.
So are you charting at the same time then?
Yeah, so I remember I talked about this, I'm like the only person, no, me and one other, we're older. I have my own system, after I have my own system, I will do my functional assessment with the patient, I have my little notepad, I'm making a couple of notes, and then I enter it into the EHR. I'm the only person. Everybody else, I don't know how they do it, and it's just, they're just amazing with it. They just carry around their laptops and they talk with the patients, and most of the documentation is done